you actually name the ventilator mode. So this will be a little bit more advanced. This will be an advanced version of the vent round session, looking at more finer details of a ventilator screen. So we'll proceed. Basically, ventilators again determined into three pieces. The mode can be broken down into three pieces. Any mode has a is basically a patient-ventilator interaction. In that interaction, you have a control variable, a breath sequence, and a targeting scheme. That is what we have been practicing in our previous sessions. In the targeting scheme, in the entire breakdown, this is the pattern that we use. We first tag the mode, which is the actual classification of what the mode is supposed to do. Then we define what is the type of load on the patient. So in inspiration, is it elastic, like ARDS, for example? Is it resistive, which is COPD, meaning due to bronchospasm or obstruction? Or is it PMUS, where there is a lot of effort? So these are the three types of loads, and we check the inspiration for these three types of loads, and we check the expiration also for these three type of loads. Once we figure out the tag, once we figure out the load, then we go to the interaction. So what is the interaction in the trigger phase? Is it normal, early, late, false, or failed? What is the interaction in inspiration? Normal, work shifting, normal or work shifting? What is the cycle problem? Is it normal, early, or late? And how is the expiration? So these are the steps that we do, and then we come to this circle on the right hand side, which is what is the goal of mechanical ventilation? Is it safety? Like in ARDS, we are trying to limit the tidal volume. Is it comfort? Like for example, in COPD patients, they're struggling a lot. They're not yet ready to be extubated, but they're struggling. So you focus on comfort there. Or is it liberation? When the patient is about to get recovering from the underlying illness, you want to plan on extubation. So you decide a mode that makes that easier. So that is the typical format. How we tag the mode also we've done before. And the tagging is based on these three broad blocks. You figure out if it is pressure control or volume control. Then you figure out if it is CMV, IMV, or CSV. And then you add the targeting scheme. There are only 7 targeting schemes. 3 or 4 of them are very common, and all of you should become well versed in these common schemes. But practice makes perfect, and that's what we've been doing in the last few vent round sessions. We discussed dual mode of targeting. We discussed adaptive mode of targeting and in the targeting schemes previously. So this is the first step, and the first step itself has 3 parts in it when you're trying to read a ventilator waveform. So the most common ones are pressure control and flow or volume control. And that is the first step to decide what is the control variable. And how you do that is by looking at the graphics. On the ventilator waveform, if the pressure control is a flat line, then it's pressure control. If the pressure time is flat line, it's pressure control. If the flow time is a flat line, it's volume control. Again, this is a recap, so I'll be a little bit quick here. There are 3 types of breath sequences. Mandatory ventilation means spontaneous breaths are not allowed at all. And the definition of a spontaneous breath is that the trigger and the cycle both must be by the patient. If any one of it is by the ventilator, then it's a mandatory breath. So the patient can start a breath, but if the machine stops it with time or volume, then it becomes a mandatory breath. Starting alone is not a criteria for a spontaneous breath. So basically, if you combine the breath sequence, you need to be sure that you can have CSV, you can have IMV, or you can have CMV. Like I said, spontaneous breaths are not allowed. And if both the trigger and the cycle is by the patient, then it is a spontaneous ventilation. These are the only 5 possible types of breath sequences. So you have pressure control CMV, pressure control CSV, which is your CPAP. Basically, CPAP and BiPAP are types of pressure control CSV. And then you have PCIMV. On the volume control side, you have VCCMV and VCIMV. So now let us just go on. This is the primer that we have done. We'll go to the actual waveform that we will try and discuss. So look at this ventilator screen. This is from one of our own ventilators that we use very commonly. And I'll just make this picture a little bit bigger. And this second screen, I'll make it smaller. We'll come back to this waveform later. So we need a volunteer. Any volunteers who are willing to analyze this in a systematic manner? Maybe from the team itself, someone can volunteer and we can start. So what is the tag here? What is the control variable? Remember we said that if one of them is flat topped, that becomes the control variable. Here, there is a label showing here. Ventilator says it's VC, and this is a Draeger manufacturer. So Draeger is saying it's VC. Does anyone want to volunteer? For someone from my team can chip in. Don't worry, there are no right or wrong answers. Well, there are right or wrong answers, but you can try. Let's see who's here. Nikhil, you want to try?
Yeah.
Yeah, let's try this one. It's a little bit of a tough one, so go for it.
Okay. Yeah.
So what is the tag here? Do you think this is VC or PC?
I would go with VC.
Yeah.
Yeah. Because
Okay. So VC is what you're calling it. And why are you calling it VC? So the rule for VC is that basically you want to see a fixed flow waveform, right?
yeah.
So that's the sort of puzzle here, right? So what we are trying to show here is that if this is true VC, what will we see? We will see
The flow initially would be straight up. It would be
like that.
like a square waveform.
Yeah, it'll be a square waveform, right?
Yeah.
So it'll be something like this. We need to see that L shape here
Yeah.
that I'm showing on the waveform. We're not seeing that. We are seeing a triangle.
Yeah.
Right? So you are guessing it's VC. That's fine. But let's think about it a little bit more. Let's analyze this one step further. Let's go back to the exactly what VC should look like. So VC should look like this guy.
Yeah.
Right? But we're not seeing this. We're not seeing that waveform. So that's a clue that something is unusual here. This is the ventilator says it's VC. So shall we just trust the ventilator and call it VC is one step that we can do. But that's the odd one out. What is the what do you think is the breath sequence? So control variable is volume. Breath sequence. PSV, CSV, CSV, IMV, or CMV.
The set rate is 18 and the patient's breathing at rate 18. So I would take it as it's not intermittent. It's kind
Do you
of.
see any trigger and any deflection?
No, I don't see a deflection in any of the.
So trigger is not by the patient for sure.
So it would be CMV.
But cycle also has to be by the machine. You think this is machine cycled?
Yeah, it's timed.
Yeah, it is timed, and there is a pause here. So there is a pause between inspiration and expiration. Right? There's a gap. There's a time gap.
Yeah.
So if there is a time gap, it has to be machine controlled, right? Because no patient holds their breath before exhaling.
Yeah.
So VC CMV is something that we can potentially commit to. Right? Continuous mandatory ventilation. We don't see any spontaneous breaths whatsoever. Spontaneous means cycle and trigger should be by the patient. Here, all these breaths are in fact machine triggered and machine cycled. And targeting scheme. So targeting scheme means we are setting a tidal volume and the ventilator is trying to deliver that tidal volume.
Yeah.
Yeah. So let's say this is VCCMVS, which is known as set point targeting. Okay.
Yeah.
Any comment on the load?
The pressure waveform definitely is odd.
Yeah.
The inspiratory pressure waveform is definitely odd.
Can you tell everyone what you think is odd about the pressure waveform? So in volume control.
In
What should it
volume
be?
control, the pressure waveform is supposed to be taking a curve because the flow goes in first, and as the lung expands, it's supposed to like reach a peak. But I mean in the pressure time scalar,
Hmm.
in the pressure time scalar, the pressure waveform from the baseline or from the peak, above the peak, it has to take a curve upwards rather than a straight rise. It's the curve isn't there here.
Exactly. So
Yeah,
that's what I'm drawing for you down.
yeah,
The flow time, F and T flow time scalar should be like this, like a square wave, and then going down like that.
yeah,
And the pressure time in volume control should be one small step up and a gradual rise.
yeah,
But what you're seeing here is a gradual rise, and then it's coming like there's a notch and it's coming down,
yeah.
right? So that is a little bit different from the usual volume control. And I think Mani Balaji has made a comment. He's talking about that it's taking time to achieve the baseline. He's talking about expiration. We'll come to expiration. So I think what is the inspiratory load here? Elastic, resistive, or PMAS? This inspiratory load can be classified as elastic actually.
The initial part itself, because it's from the initial part, you mean that?
Yeah, that initial part itself.
Okay.
And the other thing is that flow is a little bit low. So we will revisit that because the pressure is actually going quite high,
Yeah,
right? So it is possible that there is a resistance component here. So let's go to what Mani Balaji is trying to say. He's saying that in this part, the part where exhalation is happening, it's not reaching the baseline, right? So for example, if you get a waveform, how it should look in exhalation is that the normal expiratory waveform, if you're going to draw it, it should look something like this. So you have your baseline, there should be a flow going up, coming to exhalation, and then there should be a decay like this. On this, what we are seeing is a little bit different. What we are seeing is the patient's breath is coming and it's actually staying and then reaching the baseline very late in this part. These sections of the waveform, we are actually seeing that. So potentially, I mean, Malibanaji's comment is that maybe this is an obstructive, uh, problem, and that's possible. We can label it as such and mark it as obstructive as well in the expiratory load. What else? Figure looks normal, right? There's no I'll tell you the patient is actually paralyzed.
So
Yeah, Roland.
we will call it as resistive, right?
Yeah, this would be
As
resistive.
expiratory, right?
Yes,
Thanks.
yes. Thank you. Correct. Resistive pattern is what you would call it as. And we don't see PMAS, but I'm volunteering that the patient is actually paralyzed. So in a paralyzed patient, this case trigger is normal. And the inspiration, what else? What would you comment on the inspiration? Any comments? Nikhil, what
yeah.
do you think? Inspiration looks normal, right? Patient is paralyzed, so cycle is also normal. Expiration, otherwise, other than the resistive pattern, there is nothing else here. So that's also normal.
The amount of pressure taken to achieve that amount of tidal volume, the set tidal volume,
It's pretty high.
it's pretty high in the inspiratory part.
Yes.
So if the pressure is very high, and that means there is something wrong with the lung itself in the first place.
Yeah,
Could be,
yeah, that's
could
possible.
be, could be even the tube.
Could
But
be the tube, could be the tube. So that's why I just put query elastic. I'm not sure it's an elastic road, but now that we've seen resistance in expiration, there may be some elastic and obstructive resistive load on the lung there
yeah,
in inspiration. But coming to trigger the inspiratory phase entirely, there's no patient effort. So there is no, basically this box is about patient ventilator interaction, right?
yeah,
So if the patient is paralyzed, there cannot be patient ventilator interaction.
yeah.
Yeah. Okay. So now let's just go a little bit into the complexities of what I was talking about. We're 20 minutes in, we've done the basic review. We think there is something going on about this waveform that is not in line with what we are thinking. So let's go back to this tab and we'll come back to the image again. We talked about all of this stuff, and we've talked in the past about the targeting scheme. So I'm going to skip all of this. Just pay attention to this part a little bit because we'll come back here. Remember, flow time should look like this. If there is decelerating flow, it should look like the second one. And if it's pressure control, the flow time should decay like this. And if it's pressure control, the pressure time should be a nice square waveform. So please remember this, keep this in mind. This is how I would think about it. And there are a couple of comments about peak and plateau. I agree with that. It's most likely resistance. Having looked at the expiratory waveform, it's most likely resistance. But you will see why I'm not going to commit on that, because this mode is not what it seems like. So these are some of our old slides. You guys have seen this before. So we'll come back to the session proper. Back to the same waveform. You have tagged this as VCCMV, as many others did in the past as well. And breaking this mode down further, I just want you to think of some of these points. There was a setting on that ventilator that is called flow acceleration, flow ACC. This is a Draeger Savina. And the Draeger Savina, what we did was we changed the flow ACC from 65 to 110. But we did not get the flat top that we expect. And there were some abnormalities seen in the waveform that were completely different from what we expect. So look at this. This is the original one, the one that I shared with you. And you can see flow ACC. This is a setting that you will learn about in this vent rounds, is 65. And when you change the 65 to 110, observe the slope of this waveform, this bar here. When we changed it to 110, this slope has become sharper. It's become a little bit more tall. And like somebody is commenting, there is a gap. There's a big drop from the peak and the plateau. If we can call this a true peak pressure, which again we will come to and I'll explain. But what is happening here is that there is a little bit of excess exhaled tidal volume by about 50 cc. That may be explained by the air trapping potentially, where the trapped air is actually coming out during exhalation and adding to the exhaled tidal volume. Inhaled tidal volume is around 410. Very close to the set tidal volume. So you can see that doing flow ACC is doing something to the ventilator. So then we tried to analyze this a little bit further. And I actually sent this to some of my mentors. And what is happening here is that there is a flow ACC setting, which is determining the rate of change of pressure. Yet the name of the setting is flow. But when you change the flow ACC, what is changing is the pressure per unit time, which is new, very new actually in some of the ventilators. And what we dug further is that on the Draeger manual, we opened the manual and checked that the flow acceleration setting is just changing the slope of the pressure time waveform. So please pay attention to that part, because that part is critical. And if you do that, something else actually happens. So this is from the manual where we looked at PC SIMV, which is what Draeger calls it, but we checked for the specifications of the flow ACC button, and you look at the units. Look at the units very carefully. The units are millibar per second. So if the setting is changing the amount of pressure per unit time, you are actually changing the rate of change of pressure. This is a pressure control feature, meaning the ventilator is controlling the pressure. The ventilator is not controlling the flow. In a sense, in volume control mode, the ventilator controls the flow. However, here on the label of the ventilator, it says VC. But inside the manual, if you go inside the manual, it's actually telling you that you are able to control the pressure or pressure time. Yeah, Subhash? Subhash, you have a question? Okay. So the question between the two people discussing this is that this flow acceleration seems to be a misnomer, because it's not flow acceleration. It's actually a change in pressure. So flow acceleration is probably better called pressure speed, because it's a rate of change of pressure. And the other, doctor here is saying, why is that option then available in volume control? Because volume control is quite different. Now, there's another senior professor here who actually wrote some of the parts of ventilator nomenclature, is asking for the entire PDF of the Savina manual to analyze this further. So he agrees that flow acceleration definitely is a misnomer, and acceleration here should be in square time, but here the unit is just millibar per second. And this, if this is true, then that means that this is pressure speed, and therefore this must be a pressure control mode. So we open the manual further, and this is what the manual says. On the manual, if you change the flow acceleration setting, just like we found out, the slope of the pressure time waveform changes, and the flow time is just a dependent variable. So whenever pressure is the control variable and flow becomes a dependent variable, the mode is pressure control. There's no doubt about it. That's what the nomenclature says. And like one of the other viewers were pointing out, it's quite possible that there is a gap between the peak pressure and the plateau pressure. And that's correct. But if you don't have a plateau pressure, it will directly drop off. So here the inspiratory time was set as 1.2, and there was an artificially inserted plateau pressure. That is showing us that perhaps there is a resistive component. But the key point here is that all things that we have discussed so far point to some form of pressure control. So if you have flow acceleration on a Draeger ventilator, there is a high chance that that ventilator is actually not a volume control ventilator. It's probably a pressure control ventilator. So the senior professor here shares a very old equation by Merini et al. from a journal publication that says that if you change the rate of pressure as a fixed slope, you can actually use it as a pressure time variable, which is what this equation says, and you don't need to go into the details of the equation. But this is a form of pressure control, a slope guided pressure control. So Draeger Savina is a very, very common ventilator. It's there in many, many places in India. And just when we thought that the label volume control is actually what the ventilator is trying to do, if you really analyze the pressure waveform, it's actually pressure control. So the three of us were now wondering, how do we go about figuring out the intricacies of this? So we actually emailed Draeger Germany. We directly interacted with the Draeger engineers in Germany and asked them, why did you design a mode like this? What is the advantage of this form of pressure control over conventional volume control? Is there any published data to help us understand why you did this here? So this is what their reply is. What they're saying is that they wanted to replicate volume control without designing a different ventilator. They are already having expertise in turbine ventilators. And so what they're saying is that the predetermined slope of the pressure control is what is the control variable here in this ventilator. And because we are measuring the tidal volume delivered every millisecond, they're able to stop the breath when the required tidal volume has been reached very precisely. That's what the engineers are saying from Draeger directly. What's the advantage? They say that there is no clinical advantage or disadvantage from their viewpoint, and definitely no published data. There was no response to that comment. And what they're saying is that in volume control, Savina is using this term that they coined called flow acceleration, which is again in centimeters of water per second or millibar per second. So the slope starts at the PEEP level and ends if the desired VT is applied. So it's volume cycled, but if the TI is long, it becomes time cycled. The pressure source is then reduced to PEEP. And the key revelation from Draeger themselves is that the underlying control principle for driving force in Savina VC mode is pressure control. This is quite dramatic, actually. If you are a Draeger Savina user and you've been thinking of VC on Draeger as a volume control mode, this is a statement from the manufacturers themselves that it's actually not VC, it's PC. And we would not have recognized that it is PC until we went into the depths of the waveform and broke it down bit by bit like how the Ventround's platform and the format suggests. So you need to go into the tag, into the control variable, what the control variable should look like, and only then you'll be able to reveal this fact. So back to the professor, he's like, this is looking like a PCCMVS and not a VCCMV. And pressure is the feedback control variable here that simulates the external appearance of VC. So what are the potential problems here? The potential problems here are that you could misinterpret the mode, and we'll go back to some of the parts that we were talking about on the waveform. Let me share that slide again, and you can think of questions, because this is one of the more complex waveforms you will see. Yeah, Rolly, go ahead.
Yeah, I wanted to discuss that screen only. Once you will show the screen, I had some queries.
Yes, that's why I'm pulling it up. This one, right?
Yeah.
Yeah. So go ahead, ask your questions.
So this was the first in which you showed that the flow ACC. So if suppose I'm using the Drager Savina, is there a possibility in which I use only the volume control mode without this ACC feature, flow ACC feature?
That's the exact question we asked them. On this particular ventilator, on the Drager Savina, there are no volume control modes, according to the manufacturer.
So this VCCMV has got a flow ACC mode button there, right?
Yes. That is the amazing fact. Right. The amazing fact here is that even though they are calling it wholeheartedly VC, it is a simulation. What you're seeing is a simulation. The actual mode is PC. Because if this was true flow control, you would see exactly what you should see as flow control.
Right. One more question here.
Yes.
So in this flow ACC, this means that it's the ramp, right? The acceleration with which the flow goes to achieve the time. If we are increasing from 65 to 110, suppose, so that means we are increasing the speed, the flow, to reach the tidal volume faster. So is it that the ramp?
Correct.
Because if you see the second ventilator graphics, in that we see the flow time curve also is changing and the pressures are rising. So that exactly happened, because now what we are doing is we are reducing the time and the flows are high to achieve that same tidal volume in a smaller time. Is that what I understand?
And that's exactly happening. So you can see here, this is the second waveform. This is the waveform with the flow ACC at 110.
Yes.
Okay. When it is at 110, that means 110 millibars per second is the pressurization speed. Right. So if you're doing it at that speed, what you're going to see is that like you said, the tidal volume is reached faster, and the TI is still 1.2 in both.
Right.
So look at the gap here. There is a gap, and here there is no gap.
Yes.
Or very small gap.
Yes.
So that's what's happening here.
And if we see the flow time scalar in both of them, so it looks like a more the angle of the triangle is less in the first one, because it takes more time to go and reach that, and it's a more towards the 60, 70, 80 degree, like that in the second one.
Yeah, so that's exactly what's happening.
Yeah. So but still it is not a square waveform, it's an accelerating waveform, right?
Yes. So this is one of the forms of pressure control where the ventilator is controlling the slope of the pressure time, but it's still controlling pressure. Right. So Vibby's question is it set point or adaptive? I'll come to that, Vibby, in just a second. I'll come to that. So the interesting thing is, when you look at a flow control ventilator, it is volume per second, liters per second. That is the unit of flow. So what the Drager ventilators engineers have done is that they've taken volume control, taken the per second feature and adapted it to pressure. So they've made pressure control as a pressure per unit time format.
But I still have a question.
Yeah, ask the question.
But Rolly, just a minute before you go. So here it is actually the vent is controlling the pressure, thereby indirectly affecting the flow. It's not directly changing the flow.
It's not changing the flow. You can see that here very clearly.
Yeah. So what it is changing is it increased the speed with which it's pressurizing the circuit, and that's the reason why it's indirectly changed the flow. I just wanted to make that clear. So it's
Absolutely.
not the flow which the ventilator is controlling here.
Yes, it's not the flow. It's absolutely not the flow. And we have mathematical proof of that, and the manufacturer themselves are saying that. Yeah, Rolly, what's the question?
No, I got that now. So the flow remains the same, but the time taken to achieve that tidal volume is changing.
No, flow doesn't remain the same. Flow changes because remember, according to the equation of motion, flow must change.
So what is actually happening is, since the ventilator is pressurizing the circuit, indirectly flow has to change.
Yes.
But what the ventilator is doing is, ventilator is controlling the pressure. It is changing the pressure from 65 to 110. So
per second.
Per second, yeah. So through that, while achieving that, flow obviously will change.
So isn't isn't it a volume control in which the pressure is actually changing when we are changing the flow ACC?
So
The
that's
pressure is a variable thing here in the two screens.
No. So let me define that a little bit more sharply.
Yeah.
If this is volume control, like it is showing on the screen, you will only see a fixed flat volume. You have to see that, right? If you're not seeing that, then there is a dependent variable. Okay, that means if this is volume control, then pressure has to become the dependent variable. But we know that pressure is actually being controlled here. That is the only thing you can set, by the way. That's the only thing you can change for the control variable on this ventilator. You cannot change flows here. And the volume, tidal volume target just ends up being, a cycle criteria. It's not a control variable. And Rolly, to your point, SK, go ahead. You have a question. I'll come back. SK, you have a question?
Hello, yeah.
Yeah.
What I wanted to ask was, is there any corresponding flow that can be estimated for the given flow acceleration that we set?
Yes, and that is a dependent variable, and the flow is measured real time as the pressure is increasing, and that feedback
So
is
the
what the
value is there, value is seen on the screen, is it?
yes, at each point in time the correlates of the increasing pressure are shown on the graph as a flow,
Not as a number, but we
not
can't.
as a number. You will have to freeze the frame and then dial and see what the number is.
Okay. So for
So
we can get an estimate as to how much is the flow for the corresponding flow acceleration that we set, only if we freeze at a given point of time.
yeah, like for example, here you can say that the flow is say 40 to 50 liters per second at this point in time, at the peak.
All right. Thank
Right.
you.
And see, so Rolly, I'm going to explain this one more time. Look here. We are seeing that the flow is going up. We are seeing that the pressure is going up. We know that the pressure is the variable that is being controlled, and every second, this millibar, this pressure value rises every second. So there is a rise at a certain fixed rate. That's the slope. So that slope is going to cause a pressure rise every over time throughout the course of the breath. So if the pressure increases a little bit, it is going to cause a instantaneous increase in the flow. Then at the next millisecond, the flow will increase a little bit more because the pressure has risen a little bit more during the cycle. As the pressure keeps going up in a fixed interval, correspondingly, the flow behaves as a dependent variable. But the ventilator is not saying that I'm going to fix the flow throughout the breath at this rate, because the ventilator is not controlling the flow. The flow is a dependent variable. It's behaving because the pressure is acting on it over the course of the entire breath.
Okay.
Yeah. So now the other question Vibi had was, is this set point or is it adaptive? So in this case, it's actually set point, because the user has set the flow acceleration, and that is the fixed rate at which the ventilator is going to pressurize the circuit. There is no adaptive target here, meaning the ventilator is not going to change the rate of the slope to meet a tidal volume target. Once the tidal volume target is reached, it's going to cycle off. So tidal volume is actually a cycle criteria. It's not an adaptive target. So meaning the ventilator is not going to change the control variable to meet the target. Maybe if the ventilator changed the control variable to meet a target, it would be adaptive. The ventilator has to change the control variable to meet a secondary target. Only then can it be called adaptive. Yeah. SK, your hand is still raised. Any question?
No, I think I forgot to.
Oh, okay, no problem.
There's Prashant who has a question.
Go ahead. Any other questions?
Uh,
Oh, so can
Prashant.
we say flow acceleration corresponds to rise time? See, rise time is actually a little bit, fundamentally, yes, rise time from a mathematical perspective, rise time and flow acceleration would be the same thing. However, rise time is the slope for the first part of the breath in a stand. Let's say there's a typical pressure control ventilator, and on the pressure control ventilator, let me just minimize this and answer your question. It's a good question, actually. 1 second. So the question asked here is that is rise time similar? So in a normal pressure control breath, there's PEEP, then you go to the P high or the set inspiratory pressure and you come down to PEEP. Rise time is just for patient comfort. The ventilator will sometimes change the slope, will hit the same peak level and then come down to PEEP. And this slope can be different just for comfort. It can be, a slope at going like this, or it can be a slope that's very sharp, or it can be 90 degrees. Prashant, am I right so far? You're with me, right? Okay. So if that is rise time, the difference here between rise time and flow acceleration is that once the rise time period is done, so rise time period is usually the first 100 milliseconds of the breath. Sometimes it's the first 150 milliseconds. After that time period is done, the ventilator goes to the control variable, directly to the set pressure. That is not happening here. What is happening here is that throughout the entire duration of the breath, there is a pressure speed. The pressure is rising during the entire duration of the breath. It's not a rise time per se. The actual control variable is the rate of rise of pressure itself. Whereas in rise time, it just takes a longer time to get to the max pressure. Great question. You're welcome. And rise time is a comfort feature. It's not the control variable per se. Here, the control variable itself is actually pressure and the rate of change of pressure. So we discussed a few simple waveforms before. So I put up a complex one just to show you the sort of essence of this methodology. If you use the methodology, you'll be able to pick these things up that actually the ventilator manual doesn't talk about, and you'll have to actually go to the manufacturer themselves to actually understand what's happening. Any more questions? Anything else you want to talk about here? This is a paralyzed patient, so there's actually no problem with the PV synchrony. This is purely an exercise in how to tag a mode and how to figure out the control variable, the very first step. Additionally, if you want, you can see some other settings here. There's a flow trigger. There is a setting for the inspiratory time. There's a setting for the maximum pressure, which is what happened here. When the patient hit the maximum pressure, the breath actually stopped. Yeah, Nikhil, go ahead.
Yeah, why is the difference between peak going up to 65 and then plateau coming down somewhere quite below? Would there be any significance of this in the patient's ventilation?
I think, yes, there is significance. So one thing I agree with Prashant's comment is that it's quite possible that there is a resistance pattern here. But I will tell you why that plateau effect is happening in a second. Let me just expand this one also, and I'll show you a comparison. So this is with the faster flow acceleration. The image behind it is the slower acceleration. And with the faster acceleration, what happened was we hit the pressure alarm limit. And because we hit the pressure alarm limit, the ventilator would actually reduce it and stop the pressurization. So it is only stopping the rate of change of pressure. It is not opening the exhalation valve because you have a set TI. So what it did was it just stopped the active pressurization. So the ramp, the turbine giving you that 110 millibar per second, that activity has stopped. So now you have a circuit pressure that then just falls down to the plateau. If that dotted line was not there, you would continue to see the pressure rise till the set tidal volume has been delivered.
But here the tidal volume set is already delivered. It's beyond above the tidal volume delivered.
Yes.
Is there any possibility that the Pmax, why is the ventilator going till the Pmax? Could it have changed even before reaching the Pmax?
So it didn't reach the Pmax. The Pmax is the red line.
Okay.
On the Draeger ventilator, typically it starts to kick in the alarm about 5 to 10 below the Pmax.
Okay.
Okay, that's why they are showing two dotted lines, and this is there in the manual. You will be able to see that.
Okay.
And what happens is there is a little bit of a lag. So 1020 ml, yes, there will be an overlap with that. And as the patient's physiology catches up, you will get an error of those 1020 ml. So 380 becoming 410 is quite possible. But the 450 is because of what I was mentioning earlier. There is a expiratory flow that's happening because of trapped air that is coming out and being measured as a higher expiratory tidal volume. Okay, but the what I'm trying to show here is that in the speed of pressurization, the ventilator hit the tidal volume faster in the flow acceleration part that was 110. So here it hit the 380 faster, so it stopped, and it gave you more time where the breath is sitting at plateau and then transition. There is more time here. That more time is because of this 1.2 setting. Because the flow acceleration was faster, the breath got delivered quickly, it stopped there. And you compare that to here, there is less time interval here. And it didn't reach this Pmax threshold that quickly.
Okay.
Cool. What else? Any other questions? Any other comments? We have 10 minutes for questions and comments. If you want me to go over any point one more time, let me know. But I only chose one waveform because this was relatively complex, even at the first step. These are some of the older ones we discussed. I'm sure you guys may remember. And interestingly, the rise time comment is here. Prashant, this is for you. This is what a rise time would change. Great. If there are no further questions, yeah, SK. I don't know what your real name is. I'm going with SK.
Sindhuja.
Sindhuja, hi.
Hi. Can you please explain about the trigger setting in Mackie ventilators? Is it like different from the other ventilators?
No, it's very similar. Flow versus pressure trigger. This is a Mackie waveform. Here essentially there's a patient trigger which is pressure in nature. Do you have? Is it a specific question? I mean, maybe you can.
Like, if the number, if I'm setting a flow trigger of 5, so and a flow trigger of 7, it makes it easier for the patient to trigger a flow trigger of 5 rather than 7, right?
Correct. It
is same as any other ventilator, right?
Same as any other ventilator. Yeah. So this is the one you're seeing on the screen is a Mackie, and on the Mackie, what you're seeing is a flow trigger. So Mackie has both pressure and flow trigger. How do we know that this is flow trigger? Because Mackie colors it pink. Mackay will color the waveform that is triggering the breath. So if this was pressure trigger, Mackay will color this white. But this is not pressure trigger, this is flow trigger. And the functionality is the same. So if it's 3, then if there is a change of 3 liters per second, it will trigger the breath. That functionality is the same. But for other ventilators, you'll need to read the manual a little bit, and they define it a little bit differently. But the essential function is the same.
But why is the upper limit for setting the flow trigger? Like we usually don't go beyond 5. In Mackie, it is up to 10.
Yeah, see, it's a function of, actually, that's a really interesting question. And I don't know if you remember the slide from before. Let me just go to that slide. The reason for that setting is actually this slide. This one. Let me know when you can see it.
No, I can't.
You can now?
Yeah.
See, everything revolves around safety, comfort, and liberation, right? So if you have a flow trigger setting that is 10, the patient needs to generate a flow inwards of 10 liters per second over and above what the bias flow is. That's a lot of effort.
Yeah.
So from the manufacturer's perspective, if they're not able to sense even 10 or 5 or 7, then there's a problem with comfort. The patient is just not going to be able to trigger, right? Because that patient will have to generate that much flow. And in today's technologically advanced ventilators, the difference between pressure and flow triggering is actually coming down. Before, it used to be said that flow triggers are more sensitive and therefore more comfortable for the patient. But newer ventilators, especially the turbine ventilators, the pressure triggering is quite sensitive, and the comfort is not compromised as much. So there's no point in a very wide range of the flow for sensing. And the only reason to give such a high value in some ventilators is that the engineers may think that sometimes you really want to suppress false trigger. And if you want to suppress false trigger, you give a really high bar, like 10 or even 15, which frankly, you should be questioning, because that means, why is the patient having a false trigger? Why is the patient struggling so much to get that breath, is something that must go through the clinician's mind.
So does anybody actually set a trigger above flow trigger above 5 on Mackie?
Yeah, you can. If you have a false trigger from really massive hyperdynamic chest and cardiac circulation, you can set it at 5 and it will cut the trigger.
I mean, above 5, like in the range of 7, 8, 9, 10.
I haven't done that, commonly, because I would be questioning myself, like I suggested. So if it's a really young child or an athlete who has a very large and hyperdynamic cardiovascular system, they may generate enough respiratory movement in the tubing to the tune of 5 to 7 liters per second, and you may need to do that.
Okay, thank you.
But I would think it would be rare, unless anyone else has a comment. Yeah. Anything else? Great. Any other ventilator questions? It doesn't have to be from this topic. If there was anything pending from last month, please share. If you have any feedback, please share. If you want the frequency of these vent rounds changed, we're happy to consider that also.